Hi, good morning, everybody, both those who are here as well as those who are remotely. We have one of the last Chief Resident Grand Round presentations of the year, and Dr. Farmer, while remote, wanted to make sure that she had a personal chance to introduce this graduating Chief Resident who is nearly at the penultimate graduation. One more to go. But you gotta hope it's just one more, don't you? Not another one after that. Yeah, it's just one more to go after this one. So, Dr. Farmer, we can see you. I think you're live. Why don't you take it away from here?
Good morning. I'm sorry to not be there in person, but I appreciate the opportunity, and I'm thrilled to be able to be with you virtually to introduce one of our most well-known chief residents to all, Dr. Jamie Anderson. Many of you don't need an introduction, as she has served so ably as our administrative chief resident this year through unprecedented times. Who'd have thunk you had to be the chief resident to organize what to do in a pandemic? Jamie came to us from the University of California at San Diego, where she did her MD and got an MPH. But prior to that, many of you may not know, Jamie, who hails originally from Yuba City, went to the East Coast with the plan to become a spy after 9/11. Don't know what I think, how that may have helped train her for things to come, but we're glad that her interest in science ultimately took her to medicine. Jamie, again, as you know, has been really not only served all of us well, but the institution well during these unprecedented times, which she's going to talk a little bit about more today. Jamie has matched in pediatric surgery at the University of Washington, where she will be going soon, and we look forward to her continuous great service there as well. So, Dr. Anderson, it's a pleasure to introduce you to talk a bit about your perspectives on what's been happening all around us lately, and we look forward greatly to your presentation this morning.
Thank you.
Thanks,
so much.
Jamie.
Great, thank you so much, Dr. Farmer, for your introduction. So my talk today will be on telehealth and other technology, how surgeons can use lessons from COVID-19 as a catalyst for change. I have no disclosures. So it may be a little bit risky to do a talk that one of our attendings did a talk on just a few months ago, but I think Dr. Humphreys really predicted the future. You know, her talk was titled The Future of Medicine, and I think the future is here. We've really been pushed to use telehealth and telemedicine since the COVID pandemic. But I've had an interest in telehealth before this, although I haven't done much on the topic. I thought this was a great opportunity to get involved and kind of learn from it. So as Dr. Farmer mentioned, I grew up in Yuba City, a rural town about an hour north of here. My parents are actually from a teeny tiny rural town up by the Oregon border called Tule Lake. And next year I'm going to Seattle, and the Seattle Children's Hospital takes care of pediatric patients through the whole WWAMI region, Washington, Alaska, Idaho, Montana. And I really think that telehealth can really benefit rural patients and patients seeking specialty care like for pediatric surgery. So the COVID-19 pandemic, it's obviously brought a lot of challenges. A few obvious ones are the epidemiology and modeling of the virus, communication kind of from all levels, supply chain issues, and the ethics around it I think have been really, really interesting and incredibly challenging. But there have been some silver linings that I think we should focus on. One is hopefully we've learned how to prepare for future disasters a little bit better. We've also reviewed our own priorities, both in the hospital and how we take care of patients and also in our family and personal lives. And then last, I think it's really shown us how we can use telehealth and telemedicine to better take care of our patients. So in my talk today, I'll be speaking about telehealth pre-COVID-19, the impact of COVID-19 on telehealth, and then emerging technologies, and finally, a few points on how I think academic surgery should participate. So in talking about telehealth before COVID-19, I'm going to go over a few definitions, some current examples of telehealth, some barriers to telehealth, and then I'll review kind of a little bit about what we've been doing in the Department of Surgery. So when I talk about telehealth, the definition I'm going to be referring to is the use of technology to manage a patient's health by exchanging medical information over a distance. And more specifically, telemedicine is more specific to the video visits. So these are real-time video visits between providers and patients, and we've kind of grown accustomed to this now. There are a few different telehealth modalities that I just wanted to point out. One kind of distinction is synchronous versus asynchronous technologies. Synchronous is, for example, this live video visit with providers. And there are lots of different asynchronous technologies, mobile health applications, text and email that we've already been using through MyChart. Store and forward technology is a big one, radiology images. And then remote patient monitoring is kind of a new one that we've been using a little bit more. Including things like blood pressure, glucose, and pulse oximetry. These can also be synchronous if you have the right technology. I also just wanted to get your mind to think about some of the phases of care for telehealth. A lot of these correspond to current phases of care, like outpatient clinical care, inpatient care, including critical care and consultations, and intraoperative uses of telehealth. And this hasn't been done too much yet, but obviously something that we need to think about. There are also a new phase of care that I think we've been using more with telehealth, such as Forward-Triage, which is where we're triaging patients before they even come to the clinic or the hospital. So in 1995, Dr. DeBakey actually published a short article that I found talking about his experience in telehealth or telemedicine back in 1965. And his article was titled, "Telemedicine Has Now Come of Age," which I think is interesting. But back in 1965, he live broadcasted an aortic valve operation replacement with the university in Geneva, and they had a live two-way broadcast. So this is back in 1965. So while we've come a long way, we've also kind of, we're still doing that. So telehealth really kind of took off and started in 1999 with stroke response. And a lot of us who have rotated at Kaiser have seen this. If a patient comes in with concern for a stroke, the neurologist will come in via this video console, evaluate the patient, and determine if they need TPA or not. We see this all the time at Kaiser. And the results have been really remarkable. We've seen overall an increase in administration of TPA, a reduction in patient transfers, improved standardization and efficiency. And what's really interesting too is that it's decreased physician burnout. It's eliminated the windshield time that physicians have driving back and forth to the hospital, and it's decreased the burden of call by outsourcing some of the call to these telemedicine companies. And interestingly, the biggest provider for stroke care in the US is now a telemedicine company. So I'm going to go over a few examples of different ways that academic programs are using telemedicine. And the emergency department kind of throughout the US has been a big one. At Cornell, their pediatric emergency department created a virtual screening and urgent care provided by ED physicians. They originally started this service from 6 p.m. to midnight when pediatrician offices are closed and EDs are busy. And virtual visits cost $100. So a parent could call in, do a video visit with the ED physician, and determine next steps. So they found that all patients were seen within 15 minutes, and this compares to only 35% of these patients in the ED who are seen this quickly. They had short visit times, a median of 10 minutes. The providers also noted that by viewing the child in their own home, they could better assess their behavior. They didn't have kind of the fear factor of being in the ED. They reported low rates of ED referrals and admissions. Over 132 patients who had these virtual care visits, between 12 and 19% were referred to the ED. So all of these patients would have come to the ED had they not had these telemedicine visits. The providers could also order studies before the patient arrived, decreasing the time spent in the ED. And if the patients weren't referred into the ED, they could receive a phone call follow-up by a nurse or a physician the next day. If you go on their website now, this service costs around $50 and is for adults and children, and they've combined their forces with Columbia and Cornell as well. So they're keeping, they're triaging before people come into the ED. This was an interesting collaboration in Houston. Their Houston Fire Department EMS coordinated with ED physicians to perform a joint telehealth triage for every 911 response that they went to, or at least a number of them. So they published data from 2015. Together, they saw over 5,000 patients, and this is of a total of around 280,000 EMS calls. They noted that by having the ED provider on the iPad, with the fire department response team, they had a 56% absolute reduction in ambulance transfers in the ED. And patients who didn't go to the ED were made clinic appointments within 1 to 2 business days and given a taxi voucher to get there. The EMS response time decreased from 83 minutes per response to 39 minutes, which resulted in the EMS team could go to 2 additional responses per day. The city noted that they saved an average of $900,000 a year from unnecessary ED visits that were avoided. One of the barriers that the ED physicians noted is that they weren't really reimbursed for patients who didn't come to the ED, so funding for this is a little bit challenging. Obviously, overall, it was, saved a lot of money. The Medical University of South Carolina has published a lot on this topic as well. Their pediatric ICU started using telemedicine carts and peripheral examination devices to provide critical care consultations to pediatric patients in rural hospitals. They partnered with 4 hospitals in their area. These carts were expensive. They cost around $35,000, and they were paid for by philanthropy. And the consults were also free to these community hospitals. So from 2012 to 2016, they included 484 patients in their study. Most of these were actually evaluated via telephone with the critical care providers back at Medical University of South Carolina, but 62 were evaluated via telemedicine. Most actually were transferred, although 7 were determined or deemed safe to stay in the referral hospital. 64% of the patients who were transferred were able to see the consulting provider on arrival, and this improved the handoff. The same university also initiated a school-based telehealth program in 7 counties back in 2014, and they connected via secure telehealth video devices to pediatricians for kids who are at school, and this focused on asthma. So if a kid had an asthma attack, they'd go to their school nurse, they would link up with the ED physician via telehealth and provide some basic medical care. And this was reimbursed through Medicaid, and the outcomes have been really, really promising. What about in surgery? This is a study from a surgeon up in British Columbia, and they piloted a telehealth program for their consultations. They included new patients, so new consults and clinical follow-up for patients from remote communities. And they offered this telehealth alternative at a remote site, so a clinic with a nurse available. And they looked at their data from 2014 to 2017. They saw 80 patients via this telehealth consultation, and this compares to over 7,000 patients they actually saw physically in clinic, of whom 20% would have actually met criteria for remoteness. They estimated that they had a cost savings average of around $585 per visit. They reduced travel costs time by 5 hours, and this resulted in time for a time away from school and from work. So 1 missed day of school for the children and 1 missed day of work for either the parent or both parents. This surgeon focuses on pectus anomalies, and so 11 of their new referrals were actually for pectus. Their follow-up, a lot were also for pectus, but they even did follow-up for things like appendectomy, which seems crazy that a kid would have to travel 5 hours for a post-op check for their appendectomy. The surgeon also provided some opinions on tactics to improve the quality of the visit. This included having a nurse in the room at the remote site, having an electronic whiteboard for illustrations, the ability to share radiographic images with the remote site. Light shadowing and positioning during the exam really improved the quality of the exam, especially for pectus anomalies. And they also noted that when they scheduled appointments consecutively, that simulated the workflow of an in-person clinic. They did have longer appointment times to accommodate for different challenges with technology, 45 minutes compared to their usual 15 or 30-minute appointments. What about when patients are discharged? So the Children's Hospital of Philadelphia published this study. Some background, an estimated 600,000 children in the U.S. have medical technology in the home, like oxygen, feeding tubes, or monitors. And 1/3 of these children are graduates of the NICU. They have a really high readmission rate within the first 2 weeks of discharge. So the CHOP NICU from 2015 to 2017 looked at infants who were discharged from their NICU with home equipment or who required medical and surgical follow-up and offered a telehealth visit after discharge. They included 93 infants with a total of 78 video visits in the first couple weeks after discharge. 76% of these patients had surgery while they were in the hospital, so this is our patient population. They found that 12% of their encounters prompted an additional medical evaluation and treatment. So these kids, they asked them to come back to clinic and come back to the ED sooner. A lot of these were actually around respiratory issues with their trach or their vent, where the parents didn't really realize something was going on. The authors also proposed that neonatologists have a better handoff with pediatricians for these complex patients for their long-term follow-up. So we're going to talk a little bit about barriers to telehealth. The two main ones are reimbursement. I mean, probably, the top 5 main ones are reimbursement, but licensure of physicians is also an issue. So reimbursement gets muddy really, really quickly, and I'm going to try to do kind of big picture. But first, a lot of people ask, is telehealth cost effective? And this really depends on a lot of things. So first, it depends on who is paying and for what. So for patients, it can be really cost effective. As we've seen from other studies, patients don't have to, pay for that travel time, the time off of work to come in. They don't have to pay for parking. They don't have, a lot of that stress is reduced. So for patients, it may be a really great option. Hospitals may also find it sometimes cost effective if they're a rural hospital. They don't have a full-time neurologist, or it's too expensive to have round-the-clock neurologists or critical care physicians. They can outsource those specialties. So are video visits cost effective? And this also depends. So here we practice a fee-for-service model. And first, I apologize if any of this is incorrect, but this is my understanding of the big picture. And Dr. Humphreys is here to correct me later. But fee-for-service. So preventative health care, things like places like Kaiser or even the VA can do a lot of preventative health care. But preventative health care in a fee-for-service may not be reimbursable. You also, if you have higher healthcare utilization, like patients are using video visits more often, this can be costly for the system. And are these video visits and other ways that we use telehealth, are they reimbursed at the same rate as clinic appointments? So integrated models, if they are saving money in the healthcare system by using telehealth, this may be cost effective. For example, Kaiser, has a lot of preventative healthcare where they use different aspects of technology and telehealth. This could reduce overall healthcare costs. Video visits overall may be less costly than clinic visits, so that could be cost saving for the healthcare system. So let's go back to Medicare and Medi-Cal and talk about how virtual services were reimbursed before COVID. And Dr. Humphreys talked about this a little bit in her talk as well. So the three main three main modalities of virtual services reimbursed by Medicare and Medi-Cal are telemedicine visits, virtual check-ins, and e-visits. Telemedicine visits are the predominant one, and these are basically the video visits. These real-time communications between the practitioner who's at a distant site and the patient at the originating site. The two other ones are virtual check-ins and e-visits. Virtual check-ins are for established Medicare patients, and they may have a brief communication via telephone or video. You can also include video or review of images and communication with your provider. However, these cannot be related to a medical visit within the previous 7 days and should not lead to a medical visit within 24 hours. Last are e-visits, and these are non-face-to-face, patient-initiated communications through an online patient portal. And this is for established patients only. And this is, for example, if a patient is sending in a recorded image or a picture of a wound. So mostly the most common services reimbursed by Medicare and Medi-Cal were these video visits between patients and providers. Medi-Cal patients could be seen at home, whereas Medicare patients had to be seen at another clinic, like an originating site, except for patients with dialysis or opioid treatment. For Medicare, they only included rural patients, and there were limited video platforms. They had to be HIPAA compliant. So we'll kind of come back to reimbursement and talking about what has happened after COVID-19. But let's talk briefly about licensure. To provide healthcare to a patient in another state, you have to be licensed in that state. Which in California, if we want to provide healthcare to a patient who lives in Nevada, or Oregon, or elsewhere, we have to be licensed in that state. There is an interstate medical licensure compact, and this is an agreement between states to streamline this licensing process. Currently, 29 states are included, and as well as DC and Guam. Patient or physicians must pay $700 to participate in this compact. And the primary residence of the physician must be the state of physician licensure, and at least 25% of your practice must occur in that state. And currently there's no plans on having California join. I'll be moving up to Washington, so I'll be able to practice, join this compact, pay $700, and, take care of all these patients. So let's talk a little bit about what our department has been doing before telehealth. I did this little survey a few weeks ago. Thank you to those of you who participated. 46 people responded, including 23 attendings, 16 residents, and 7 nurse practitioners. So how many video visits have you done before the shelter-in-place policy, the second week of March? Of the faculty, 13 hadn't done any, although 2 had done more than 20. Only 2 of the nurse practitioners had done a few video visits, and none of the residents had done any video visits before shelter-in-place. We'll come back to this. So let's talk a little bit about what COVID-19 has done for telehealth. So the CARES Act, and you'll see kind of references to this waiver 1135. So the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act. The main changes for telehealth are these. Patients living in any geographic area can receive telehealth services, not just those in rural areas. Patients can access video visits from their home. They don't have to go to a clinic. Video visits can be delivered via smartphones and via a variety of different modes. So you can use Skype and FaceTime, even though those aren't HIPAA compliant at the moment. It removes requirements for pre-existing relationships between patients and providers. You can see new patients you haven't met before. Reimbursements are also the same as in-person visits. And there's also been additional funding for the Telehealth Network Grant Program, $29 million for 5 years that started this year. Yuba City actually had got a big grant for this. So how are we reimbursed? So it's my understanding when a patient goes to clinic, we charge patients for 2 things: the professional fee, which is the charge for the physician and their expertise, and the facility fee, the charge for the clinic overhead. And this varies by clinic and how the clinic is designated. So for example, so my dermatologist was telling me that she has a clinic on C Street. That's considered a hospital-based clinic. People who have Medicare pay a much higher fee if they go see her in that clinic versus if they go see her out in Roseville. So they will drive to Roseville to see her out there because it's a lot cheaper for them, even though it's the same person providing the same care. But under this waiver, the professional fees for Medicare and Medi-Cal will pay the same as the inpatient visits, but the facility fee is different. And this right now, and this is new, is reimbursed at a flat rate of $24 per visit. And so if our facility fees are comparable to $24, these video visits may be cost effective at the moment. But if our fees are much higher, we may be losing money. And there's a lot of economics that goes into this and paying for the clinic and that kind of thing. But right now, this is kind of what my understanding of what we are being reimbursed for. So what about private payers or group insurance plans? And right now, a lot of insurance plans have kind of individually moved to this as well to follow Medicare and Medicaid or Medi-Cal, but there are no kind of laws around this. Most of this legislation currently is specific to Medicare and Medi-Cal or Medicaid, not these private payers and group insurance plans. Here in California, back in October, state law was passed that mandates that all insurance providers must cover telehealth services at the same rate they cover in-person services. And this is supposed to take place this coming January. Currently, there's similar legislation planned to be introduced to the U.S. Senate, but this is only applicable during the COVID pandemic. And currently, there are no plans to have telehealth service expansions extend after the COVID pandemic. So these right now are all just temporary. But people are using telehealth. This was a poll done about almost a month ago now, just in the U.S. And 23% of all adults have used telehealth for an appointment with their doctor since the COVID pandemic started. And interestingly, by age, this even baby boomers are using telehealth. So it's not, it's not just millennials and Gen Xers. It's kind of everyone. So how else has COVID-19 changed telehealth besides doing the video visits? Forward-Triage, as I've kind of mentioned before, but a lot of hospitals are using this for evaluating patients who may have COVID-19. So patients think they have symptoms, they call up this, triage telephone number, and they're triaged to testing centers or clinics instead of hospitals, and maybe hospitals if they need it. Over 50 U.S. health systems have programs. I imagine that this number has, expanded quite a bit since this short paper was published. And other systems, healthcare systems, have outsourced these services to some of the telehealth companies, like Teladoc and Amwell. I'll talk about those in a minute. We're also using telehealth in the hospital. We've seen, we now communicate with patient families via iPads quite commonly to provide some of that support since family members can't come into the hospital anymore. Seattle Children's published a short study back in February. Since everything started to happen, they have locked down their NICU a bit more. They've used this InTouch Vici telemedicine cart, the digital stethoscope. The nurses use the stethoscope, and this minimizes the number of providers who come into contact with the patient. So since using this, they've gone from an average of 21 providers seeing each NICU baby to an average of 7 providers seeing each NICU baby. So even within hospitals who have all these resources, we've been able to cut down on contact and hopefully reduce transmission. So since COVID-19, since the shelter-in-place policy has been enacted, how many video visits have we done? Faculty members, still 5 of them reported they haven't done any. I think this number is probably a lot higher. But 8 have done over 20 since the shelter-in-place policy has happened. Nurse practitioners, everyone who responded has done at least 1, and quite a few are doing more than that. And the residents have now started to do a few video visits as well, although the majority have not. So when asked, where do you perform video visits? Most people, not surprisingly, do it in clinic, although among the faculty members, some are performing these video visits in their academic office or even their home office. When asked which patient visits do you think are best suited for telemedicine, most agree that post-op visits and routine follow-up visits are best suited for telemedicine. But some people still think that new patients and pre-op patients may be suited for telemedicine. One faculty member doesn't think there's any appropriate patient for telemedicine, and I really challenge them on that. We also asked, what percentage of your clinical visits do you plan to do via video visits when there are no further COVID restrictions? Most fall around 50%, but you see the trend kind of leans less than 50%. So we also asked what improvements are needed here at UC Davis, and there were a lot of great suggestions. I'll just highlight a few of these. One, a lot of people talked about technology and having better technology. Including the ability to take pictures and save them in the chart, having the ability to share labs and study results between UC Davis and surrounding institutions, easier scheduling, better coordination for allowing trainees to do these video visits. Around the clinic and support, it'd be nice to have a suture removal clinic with an RN or an MA. There are some challenges with real-time IT support, although there is a help desk available. Scheduling all video visits during the same block time may improve efficiency. And then there's a lot of questions still, I think, around the video visit structure. Do we have a standardized format? What's the best way to do a physical exam? Reimbursement is still a big question. And then networks, I think, is always a challenging one. How do you provide incentives for remote providers to want to do video visits with specialists? How do you create those networks? So Dr. Humphreys could talk more about this later, perhaps, but we are making improvements to the video visits and our technology here at UC Davis. There will be a pilot project around this in June, and this will likely roll out in the fall. There are a number of improvements. First, it increases the number of people who are able to join a visit. You can have more than 3. Residents can also start the visit, and a faculty member can join later. You can access through the desktop, through Epic. Patients can also take a photo during the visit, and it will be automatically uploaded in the media tab. So a lot of changes are still coming. So let's think about a little bit beyond video visits and talk more about emerging technologies and some bigger things to think about. So, if we think about it, the internet's been around for a while. The iPhone came out in 2007, and we are about at least a decade behind, I think, in medical technology. We now have devices that track our heart rate, track our steps, track where we are. We have smart speakers that are now HIPAA compliant, and also track potentially what we're saying. There's a lot of new devices, and how we integrate this with our current care, I think, will be really interesting in the future. And I want to really propose that telehealth is not just this traditional model of a doctor-patient interaction with the assistance of communications technology in the middle, but it can be this systems-wide change with some big money and tech companies involved. If you're going to invest in anything right now, I think this might be where it's at. The market for this has just grown exponentially. I want to highlight a few companies around telehealth that you may not be aware of, but I think that we all should be aware of, and that this is really coming. It's here. So SOC Telemed is one of the biggest telemed companies for neurology, for stroke care. They provide consultations for neurology, for psychiatry, and for ICU care. And they also provide kind of this turnkey platform where if you're a small hospital and you want to start doing more video visits and you want to have access to these consulting services, they'll come into your hospital and kind of give you this one-stop platform. Doctor on Demand, they are providing urgent care, chronic care, behavioral health, and preventative health to patients directly. So this is a service offered. Patients with or without insurance can sign up. They also offer it, for example, say you're on vacation or you're moving and you're in a different state, but you need antibiotics. You can call up, log in on your smartphone and pay for this flat rate service. These are the prices if you don't have health insurance, which I think are pretty reasonable. Obviously, it's for a limited number of services, but this is kind of a new method of providing healthcare. Employers can also sign on for their employees. So if you run a business, in addition to providing healthcare, you can provide the service as well. And their physicians are either employed or they're contractors. Amwell is a big company. They provide two main services. One, again, is this platform for providers to augment their current practice to provide video visits to their patients. They have over 2,000 clients, including Cleveland Clinic, New York Presbyterian, Intermountain Health. They've also started this direct-to-consumer service, like Doctor on Demand, since 2012. And this is the company that's integrated into the Apple Heart Study that I want to take a minute to talk about. A lot of you may know about this. This was a partnership between Apple, Stanford, and Amwell. And Amwell was the company that provided these telehealth follow-ups for patients with these arrhythmias. So in 8 months, they recruited over 400,000 patients. That is an astonishing number of patients. And anyone who bought an Apple Watch was asked if they wanted to recruit or to be involved. Over a median of 117 days of monitoring, they had 2,000 participants who received a notification of an irregular pulse. After that, those patients were mailed an ECG patch that they would wear for 7 days. 450 of these patients had an ECG patch that could be analyzed, and 34% of these were found to have atrial fibrillation, and most episodes were over an hour. So these authors surmised that they could identify some patients with atrial fibrillation and could subsequently alert them or their providers, like Amwell, if they went into AFib again and reach out to these patients. So what about Amazon? Amazon's also probably making a ton of money right now, and this will be, in my neighborhood pretty soon, or I'll be in their neighborhood, I guess. But they are providing virtual and in-person healthcare services from a company called Oasis Medical to their Amazon employees in Seattle. So their employees already have healthcare, but this is an extra service they're providing. And they offer acute, urgent needs like URIs, minor injuries, sexual health, travel health, preventative care. They offer a care chat, an in-app text chat 24/7. They also offer video care, mobile care, and care courier from 6 a.m. to 10 p.m. So if you need labs drawn or if you need a vaccine, they will send a nurse to your house to do this. And if you need a prescription, they'll deliver it within 2 hours. So these companies are really, kind of changing the way I think a lot of people are going to be receiving healthcare. 5G is coming out, and other people can probably know more about this than I do. Dr. Hiroshi can probably talk about this. But there's the promise of 5G is that by having much faster connectivity, devices can potentially work together in cohort, and the latency time really is diminished. Recently, the British Journal of Surgery published this paper where they used 5G between an OR and a group of kind of surgical mentors in another room. So they performed, two separate teams performed LARs, and they had a group of these experts kind of several miles away and providing tele-mentoring. So the surgeons in the conference room could talk directly to the surgeons and draw on their screens, which they call telestration. The lag time was incredibly quick. That was basically like they were in the room. And they did this in Barcelona and in Shanghai. So, it's still pretty similar to what Dr. DeBakey did back in 1965, but I think the speed has just rapidly increased. So I want to propose that I think we're at a time when we're really going to see a paradigm shift between discrete healthcare visits and something else. So right now patients come, if they're sick, you come to the hospital, you get seen by a physician, you go home. You come to the hospital, you get labs, you go home. You come for your hospitalization, and then you go home, and maybe you don't interact with the provider very much in those other times. But with new technology, I think we're really going to start to see, and I think we should try to work on, how can we integrate this data that we're already collecting on patients and that we have access to really support health and identify illness. How are we going to identify COVID outbreaks more quickly? When there is an outbreak, how do we track and find those contacts? We have everyone's GPS information, and we can see where you've been. It's a little big brother, but I think with all this technology, healthcare can be a little bit more fluid in the way we're delivering it. So last, I want to end just with a few comments on how I think academic surgery should participate and try to get everyone thinking a little bit. So teaching, research, clinical partnerships, and research networks, kind of the bread and butter of academic medicine in my mind. So teaching. Clearly, I think we need to improve resident involvement with telehealth visits. And I think it's challenging because a lot of us don't really, the attendings as well, we don't know how to do these video visits well. How do we ensure full confidentiality with the patients? How do we set it up so that patients will, divulge their information? How do we do a good physical exam? We're still kind of learning how to do that. And we also need to figure out how to get residents involved. Teaching medical students via distant learning is a whole other can of worms, but I think we really need to start thinking about that. So research priorities. These are just a few things that I think we, if we're doing research in this realm, we should really think about. Are we meeting the demands of patients and the needs of providers? Do we need to define new metrics? What are some patient-centered outcomes around telehealth? How do we ensure quality of care? How do we ensure equity of care without perpetuating disparities? How do we improve healthcare value through technology? So we have a great resource here at UC Davis, the Center for Health and Technology, the building next door to us. And I encourage you to check out their website again and see what things they have going on. I want to bring up a few different research projects that are happening here in the Department of Surgery. So the trauma department has partnered with the emergency department to look at family-centered pediatric trauma care. This is a massive grant. It's $4.2 million from PCORI. And they are looking at when pediatric patients at distant emergency departments, when it's decided that they need to be seen here at UC Davis and be transferred here, they are connecting the patient and the family members to our trauma providers here. So that to provide a better handoff. So when patients get here, the families have already met the trauma team. They kind of know what to expect. The outcomes they're looking at are the patient and family experience of these video referrals compared to families who don't get the video referrals before they're transferred. They're also looking at out-of-pocket costs to the family after the injury of a child. And Dr. Galante is one of the co-PIs on the project, and Dr. Rinder Connect is one of our trauma attendings who's kind of the point person if you're interested. Dr. Cook is working on a project around telemedicine adoption by African American patients. He's looking first at baseline data of telemedicine utilization and demographics among UC Davis patients before and after February 19 of this year, and then doing a qualitative study. So they're interviewing African American community stakeholders to elucidate barriers and solutions through focus groups. Their ultimate goal is to increase adoption of telemedicine by African American patients with the possible applicability to other vulnerable populations. Post-op hands rehab. The plastic surgery department has a really great name for their study, the HAVOC study, which stands for Hand Therapy App Video Visit Optimized Care Study. And for their post-op hand patients, they're doing video visits and also hand therapy through an app. They're comparing this virtual care cohort to outcomes from the last 3 years. They also received funding from CHIPR through this COVID-19 research program. So I do want to challenge you to think about how can we stay competitive here at UC Davis, and how can we partner with other clinics and hospitals in the Northern California area. I think also the University of California being a UC, we have an opportunity to really partner with some of our other UCs around the state to really work on some of these issues. And maybe we should partner with tech companies, or it's something at least to think about. So for closing thoughts, how can we use technology to improve value? How do we improve the quality and outcomes for our patients before surgery, during surgery, and after surgery? And how can we use telehealth to decrease the cost of accessing healthcare for our patients? So that closes my talk. I want to say a huge thank you to the Department of Surgery. It's been a great 6 years. I think residency is the best. We've gotten to do so many amazing things. A special thank you to Dr. Harisi and the Pediatric Surgery Department. Thanks for all your mentorship. I also included one of our great scrub techs, Aida, to give a shout out to all of our scrub techs and nurses who have helped us along the way. In addition to pediatric surgery, there have been a lot of surgical mentors for me and research mentors, Dr. Bull, Dr. Campbell, Dr. Jerkovich, quite a few others that I've done research with. And then our leadership, Dr. Farmer has been a great supporter of me since the beginning. And I really value her mentorship. My original program director, Dr. Galante, and then Dr. Salcedo, my new program director, thanks for supporting me throughout it all as well. And then a thank you to a lot of other special people. My residency cohort, we were all a little nervous when we found out that there were 7 women and only 2 men in our intern class, but thankfully we've all been really great friends, and we've grown a lot. So there have been a lot of weddings and babies born in the last 6 years, which has been really, really fun. Special thank you to my family, my parents and my brother. Whenever I think that I'm working hard, I think about them. Right now, they're working like sun up to sundown, and they were really been a huge support and inspiring. And it's been really great to live near them and kind of see my nephew and niece grow up. And then thanks to Jesse, my new husband. We got married a few months ago, so thanks for all of your support as well. So with that, thank you again, and I'd be happy to take any questions.
Jamie, that was outstanding. You combined your future career in pediatric surgery, your current exemplary performance as a resident, and the COVID era pandemic, along with stock investment suggestions, all in one grand round. So that's a remarkable accomplishment. Well, I'm going to start from the field and see if we have any questions, probably.
We have a question from Dr. Ian Brown. He says, fascinating. Has anyone looked into more widespread use of technology for improved trauma triage through interactions between first responders and trauma centers, or more standardized pre-transfer assessment for trauma transfers?
Yeah, and I think he's referring to that Houston study where they're looking at, telehealth with ED physicians, and I don't think so. I haven't seen any. Maybe Dr. Schatz knows of something with the pre-hospital triage, but I haven't seen anything, at least to that degree.
I'm a military guy. So the military has a huge experience with the FAR 4 telehealth that I would say hasn't quite got translated back into civilian practices yet, but there's lots written about it, so I imagine it's not that far away.
Jamie, it's a great talk, and we're all incredibly proud of you. And watching you grow and develop as a resident is really, an amazing thing for us to all watch. And we hope you keep us in mind when you're looking for a job. I wanted to mention two things that you touched upon in the talk. I think it's really important for us to recognize. One is the disparities thing. So the one thing that our division's been really forward on doing video visits and doing telephone visits, actually trying to reduce the travel time for our patients. And the one thing you realize with video visits is that there is a real disparity. And in some ways, it makes it worse in that the people with decent Wi-Fi can have a decent visit. And even if they have a phone, if they have crappy Wi-Fi, it really makes the visit deteriorate quickly. And I'm curious what people think we can do about that. And that's sort of interlaced with the idea, and you touched on it with that Kaiser slide and the CMS slide, because what no one wants to talk about, what this COVID experience has really made clear to me, is that we have a dichotomy in medicine that the hospital's insurance company, insurance companies are actually on the patient side. The doctors are not on the patient side, and that we benefit from sickness.
Yeah.
And so as long as we're in this situation where we get paid to take care of the sick, we actually have a motivation to have sick patients, whether you want to believe it or not. It may not be that we want to keep them sick, but we have a motivation to have sick patients, right? And so the flip side is that if you're a system like Kaiser or even an insurance company, you're actually motivated to keep people healthy, right? Because you pay less for healthy patients. So I think that there's sort of linked concepts in that, the disparity of healthcare and access has a lot to do with the fact that we have this model where money comes from the sick patients, and if you're poor, you're sort of hosed. And I don't see an easy way to fix that. I was thinking maybe we give the patient somehow kind of, maybe with 5G, we can give them a device that lets them connect with us and they send it back and whatnot. But this is not, I don't see a good solution. I was wondering if you had come up with in your reading, anything that resonated, because I've not found a good way to fix this problem.
No, I think you've hit the crux of the issue. It's a huge problem. I think even if we give, like you pointed out though, even if we give patients 5G phones, we're not being reimbursed if they don't come in, right? I think that just points to the need for a bigger overhaul of the way funding mechanisms work overall.
So, Shin, I'll comment a little bit on that, because there are partnerships with industry. So industry giving people devices, which is one of the things that some of the orthopedic groups the orthopedic companies have done. It doesn't help with everything. There's a huge initiative in the California legislature called Broadband for All, so that any fiber optic that's laid down now it would allow for people in all places to get that. And the goal is, with a lot of telehealth push from the backside, is that would help increase the ability for patients, even in rural areas, to get this. There's also an idea of asking hospitals in rural areas to become telemedicine hubs. So the residents in that region could go and use the Wi-Fi in that hospital to do potential telemedicine areas. But industry, in certain fashions, do give people devices. I've seen it mostly in like the knee replacements. So they give the patient a device afterwards, they connect with that patient, they follow that patient, they help them through therapy, and then when that is done, they get it back. Again, that's a sick person getting it, and that does rely on the fact that they have to have some access, but partnering with some of those companies may be where we need to go to.
I would just wonder what the motivation for the company is.
I don't know, but it was really interesting to see it when they...
It's
Yeah.
always fun, right?
Yeah.
The thing that strikes me is when you travel in other countries, Wi-Fi is so much easier to find in other countries than it is here. It's almost like Wi-Fi is considered like water and sewage.
Mm-hmm.
And here, Wi-Fi, I'm telling my patients to go to McDonald's and sit outside, or go to the library, or go to Starbucks and sit outside, so they can do video visit with me in the car.
Yeah.
But one of the things that they face with complications of that is in places like Africa, where people do have a lot of access, they don't want to use their minutes sometimes on healthcare. So there is still competing interest in those places as well.
Dr. Schatz?
Yeah, it's great talk. This may be above your pay grade and maybe more for Dr. Humphreys, but we've been trying to get this telehealth stuff into place for years for the trauma patients. There's tons of trauma patients that come here that don't need to come here.
Yeah.
But it always seems to be the lawyers that block it. It's the HIPAA compliance. It's the whatever it is, but the technology is there. There's other systems in our Northern California have been doing it just fine. So what is the obstacle for UC Davis to be able to connect to all the rest of the hospitals in Northern California to look at the scans, look at the patient, and say, you don't need to come here, we'll see you in clinic next week?
Yeah, maybe Dr. Humphreys can comment, but I do think this PCORI grant that we have could really set the stage for more of that. It's not the end-all be-all, it's patient outcomes, but I think by proving that the technology can work and be potentially HIPAA compliant, that could be a really great first step. It's not really the most direct way to do it, but I think it could really help out. Dr. Humphreys, do you have?
You and I have talked a little bit about this. Some of it is driven by lack of transfer of images. So it's really challenging for some of the hospitals to send image transfer here. The TeleStroke program has opened that up, and they're buying a new system so that images can be transferred here almost immediately, and that's all centered around TeleStroke. Hopefully that will help with us being able to see images for patients in these remote areas. But I think it initially is going to have to be provider-driven. Just like video visits needed to be provider-driven before COVID, with faculty saying, hey, why don't we just see you back as a video visit? A lot of the physicians can't fathom necessarily what that would look like. I think the COVID epidemic in doing more video visits has. And then there's always concern for liability. If you leave that person up there, and we are a place that wants to not miss anything a lot of times. So that comes with it too.
Online question?
This is from Dr. Farmer. She says, great presentation, Dr. Anderson. You spent your research years working on national surgical plans in Nigeria. How do we get a national surgical plan in the U.S., and do we need one?
Yeah, I think the American College of Surgeons in this COVID pandemic has shown some leadership in providing some priorities during this kind of pandemic time. The National Surgical Planning has really been focused around getting patients access to essential surgical care in a timely fashion, so within 2 hours. I think a national plan in the United States is probably too much probably won't happen. A state-by-state plan could potentially be a possibility, and I think would be fantastic. I think it really does matter in places with huge rural areas. Northern California, California is one of them. Do our patients have access to essential surgical care within 2 hours? I think most probably do, but there's probably some that don't, and how can we improve that? And I think telemedicine and telehealth is one way that we can really improve that and cut some of that time.
Okay, anything else? Jamie, congratulations.
Okay, thank you so much.
You.
Thanks.
All right.